Hi, class. We're going to talk today about symptom management and symptoms that we commonly see in patients with illnesses. And so this slide was put together by Connie Carr and me, and we have one video in it, so hopefully it works this time, so we'll see. All right. So let's talk about constipation. It's a great topic to start on because it's something that we see quite frequently in many patients, especially patients who are on different types of drugs that can affect our GI system. So constipation is when stools are decreased in frequency or may be difficult to evacuate. Most common side effects with constipation are because of opioids, and then we'll go over the Rome criteria. Functional constipation. So this is the Rome criteria. So at least 12 weeks, which need to be does not need to be consecutive in the preceding 12 months of 2 or more of. So that means that basically that they have constipation, but they have periods where it seems to be functioning okay within the 12 months. And in those 12 months, they have to have 2 of the 4 of more of these different types of symptoms. That's either straining for more than a quarter of their defecations, or lumpy or hard stools for more than a quarter of their defecations, sensitization of incomplete evacuation for more than a quarter of their stools, so meaning that they feel like they still have stool inside their GI tract, sensation of anal rectal obstruction or blockage in more than a quarter of their defecations, and needing manual maneuvers to facilitate a defecation, meaning that they have to do a digital evacuation or support from the pelvic floor, either that or from medications. Or if they have less than 3 defecations per week. These are all types of functional constipation under the Rome criteria. So we're going to go a little over anatomy of your large intestine, which is the main source of where your stool is formed. So you have the ascending colon connecting to the transverse colon, to the descending colon, into the sigmoid and the rectum. The primary function of your large intestine is to reabsorb water. It's where waste material is passed out through the rectum. It's also where we have storage there for bacterial colonies, and they also produce some organic nutrients. And the excess waste is relieved through your anus. The functions of the large intestine is they absorb water and certain electrolytes, synthesis of certain vitamins by intestinal bacteria, so that's where your potassium and your K and some B vitamins are actually synthesized by your bacteria. So that's why we need intestinal bacteria. It's good bacteria as long as it stays in our intestines. It does not become good bacteria if it goes out of our intestines. It is also a temporary storage for the feces, so that's where we hold it. It helps eliminate waste from the body. And the peristaltic waves help make the fecal matter move throughout the cecum and into the ascending and transverse and descending colon. So it's important to have those peristaltical waves to help move the stool throughout the rectum and large intestines. This is a KUB, or abdominal X-ray. And when you look at the circles, that's areas of fecal matter. You can see the stool is white, surrounded by black bowel or gas. So if you look here, you can see right here is stool, and then up here is like gas. Stool, stool, same thing up here. Stool, stool, gas. This is someone that is full of stool, and you should be able to see that quite clearly. Look at all this right here. I mean, this person's going to need quite a bit of help to get this out. You can almost see how it goes through the whole tract and into the rectum. look at causes of constipation. So you probably already know that opioids is a huge cause of constipation. So medications, basically it stops the peristalsis from happening. So the wave-like motions don't allow the stool to go through the large intestines and out the rectum. Decreased mobility can do that too. Moving, exercising helps with the peristalsis. If you have an ileus, so there's nothing moving in your GI tract. Mechanical obstruction, whether that be from a cancer or abdominal adhesions. Metabolic abnormalities, spinal cord compression, dehydration, autonomic dysfunction, malignancies, and other diseases that basically stop the normal process of the peristalsis waves, which is like hypothyroidism, diabetes, Parkinson's disease, gluten-related disorders, colon cancer, diverticulitis, inflammatory bowel disease. So let's try to get this video for you to see.
Constipation. We will discuss what is it, what does it look like, who gets it, and how do we treat it. Constipation is simply defined as a disruption in normal bowel movements. Normally, people have a bowel movement, or BM, every day or every other day. If you do not have a BM for more than 2 days, the stools can become hard and difficult to pass. This can lead to abdominal discomfort, bloating, nausea, as well as pain, blood in the stool, or hemorrhoids. Anyone can potentially experience constipation. Risk factors making constipation more likely include poor diet, dehydration, and decreased activity. Patients with cancer can have a higher risk for constipation due to several additional factors. For example, if there is a tumor in the intestines or rectum, it can directly block stool from moving through the digestive tract, which prevents the ability to have a bowel movement. Additionally, certain chemotherapy drugs can cause constipation by slowing the movement of food through the digestive tract. Strong pain medications such as opioids are a common cause of constipation. Opioids slow down the intestines, causing the stool to move through them much more slowly than normal. Some of the more common opioids include morphine, oxycodone, hydrocodone, hydromorphone, and fentanyl. And don't forget, this kind of constipation will only go away once opioids are no longer taken. Opioids cause the stool to sit in the colon or rectum longer, allowing more water to be absorbed. This can lead to harder stools and straining when trying to pass them. Stool can become so hard that it feels like a rock. If you take pain medications, you may need to take Docusate or Senna daily to prevent constipation. Docusate is a detergent that coats the stool, causing it to absorb water, and Senna is a natural plant laxative. Docusate plus Senna is combined in one tablet known as Senna S. If you are taking Senna and Docusate and are still constipated, speak to your doctor or pharmacist about additional laxative options that are safe for you. How is constipation prevented? Walking helps stimulate the intestines to move stool down the intestinal tract. Check with your doctor before starting any new exercise program. Remember, it's not always what you eat, it's what you are not eating. Fruits with edible peelings such as apples, peaches, and raspberries may help. Vegetables are also a great source of fiber. It is important to know that some doctors recommend all fruits and vegetables be thoroughly cooked for people with poorly functioning immune systems, such as those with acute leukemias. In addition to grains such as whole grain breads, oatmeal, raw fruit, and veggies, fiber can be purchased at your pharmacy or grocery store as a tablet or powder supplement. Fiber supplements such as psyllium, shown on the left, works by absorbing the water you drink and locking it into the stool to prevent it from hardening. After mixing psyllium with water, it grows in size within the intestine. Then, similar to unclogging a blocked drain, psyllium works by flushing stool through the bowel. There are many other medications that can help you have a bowel movement. Other oral laxatives are available. Although some are prescribed, many are available over the counter at your pharmacy. One class of medications are laxatives, which work by either causing the intestines to move faster or causing water to stay in the bowel, allowing stool to pass through easier. Because not all laxatives are safe for everyone, ask your doctor or pharmacist before trying the laxative. Commonly available over-the-counter laxatives include magnesium citrate, bisacodyl or Dulcolax, polyethylene glycol or Miralax, or Senna S. If over-the-counter medications are not successful, ask your doctor about one of these prescription medications, such as lactulose liquid or methyl naltrexone. After receiving chemotherapy, enemas and suppositories are not recommended, as they could lead to a puncture or tear in the rectum and cause a severe infection while your immune system is recovering. Remember to stimulate your colon by staying active, drinking plenty of water, include a healthy amount of fiber in your diet, and minimize constipating foods. Subscribe to our YouTube channel and tell us what you.
So that was just a nice little video about constipation and going over a little bit about what you may see for patients who are getting chemotherapy. However, that also works for other patients who have constipation. They did briefly go over some management for constipation and the causes, as we talked about. When we look at different types of agents that we can use, I want you to remember that the docosahexaene sodium, what they talked about, what they call the mush, it's really just like detergent soap that you're giving a patient to soften their stool. It does not create peristalsis, so that's why you have to combine it usually with senna. Senna is a natural substance. It's a stimulant. It will help with the peristalsis. It comes over the counter. Many of these drugs actually come over the counter so that they can take. Bulking items, which is like the psyllium tablets that they can use. In children, if they don't want to take meds, there is sugar-free licorice that has psyllium in it. And basically they just eat a bunch of licorice and it will help them relieve their constipation. So just a little fact for anyone who has children who won't take meds and has constipation. Things that they talked about for opioid agonists, and that's the methanoltrexone. Now, with methanoltrexone, it has like a derivative of Narcan in it, but it focuses more on the GI tract. And so methanoltrexone is really only for constipation that's related to opioids. It is an injection that you give. It's a very expensive injection, so we don't use it that often. We try to use other agents that are much more cheaper, but it is effective in patients who have constipation related to opioids. The stimulants are the senna, bisacodyl, and actually Regland, which is a anti-nausea medication, and then we'll go into Regland a little bit later, but it also is a stimulant for GI. So if you have a patient with nausea and also may have some functional constipation, Regland can be very helpful to treat both of those symptoms. I would not recommend necessarily just using Regland alone for someone who has constipation. It's not as effective, but it's effective in someone who has nausea and may have a little bit of constipation. Enemas we use quite frequently, and those are for patients who do take an oral medication, but they still haven't had a bowel movement, and so they need to have either like a Fleet's enema or a suppository. So you kind of think of it as your GI tract is one large pipe, and you can take meds from the top to get it to move. However, sometimes if you have a significant stool ball, you may need to also give something in the rectum, so basically hitting it from the behind to get it to go for a bowel movement. Lactulose was something that they talked about, and it's an osmotic, and we do use that. It can cause significant cramping. It's pretty effective. We all basically use lactulose in our liver patients who have encephalopathy, right? Because it pulls ammonia out, but it also, what it does is help pull it into the stool, and so you defecate it out. And when we use lactulose, we use it not as a medication that is a daily thing for someone who has like a functional constipation. It is for usually like a one-time only to get someone to have a bowel movement who has been significantly constipated. Okay, let's move on. Let's move on to dyspnea. So we have a little fish here saying I'm having trouble breathing, most likely because he's outside of the water. So dyspnea is an uncomfortable sensation or awareness of breathing or needing to breathe. Shortness of breath, which doesn't correlate with the oxygen saturation or your respiratory rate. And it is a subjective finding. So dyspnea is a subjective finding. Now, tachypnea is not necessarily a subjective finding. That is you watching the patient and how fast they are breathing. Are they breathing over 20 times a minute? So we can use a respiratory distress observation scale for you to help determine if a patient is having some distress with breathing. And you can give it points based on each of the categories that is listed here, 2 points if they are having distress, and 0 points if they seem to be in the normal range. And it goes over heart rate and respiratory rate, whether they're restless, non-purposeful movements, which is usually signifying that they're uncomfortable, paradoxical breathing, so right, it's not breathing correctly, when your abdominal moves with the inspiration versus your chest. You're using accessory muscles, so that means you're looking at your clavicle, your rib muscles. Are they being used more vicariously than normal? Are they looking like they are really straining to breathe? And you'll see it mostly up by their clavicle and then their neck if they're having like significant difficulty with breathing. There could be grunting at the end of expiration and nasal flaring, which is the involuntary movement of the nares. And if there's a look of fear, like eyes wide open, facial muscles are tense, they may have furrowing of their brow, open mouth, or clenched teeth. Now, respiratory distress observation scale is not used as a substitute for patient report. So they could have all of those symptoms that are listed on the RDOS, but they could also say, no, I feel fine. So you go off of what the patient is able to say to you. Now, if they're nonverbal, then you use the RDOS. It is only an adult assessments tool, obviously based on what it says for the rates and heart rate. That is not for a child, so it's only for adults. You can't be used when a patient is paralyzed or has a neuromuscular blocking agent. And when you do count for the respiratory and a heart rate, it's for 1 minute. And you can actually hear grunting in intubated patients too. So don't just assume that because they're intubated, you may not hear it. And as we said, fearful expressions is also something to watch for. So let's go through the pathophysiology of dyspnea. So it does occur in your CNS where there is a mismatch between the efferent and the afferent signaling. As the brain receives information from the afferent ventilation, it compares it to the current level of the respiration of the efferent motor system, right? And if the respiration is inappropriate for the body's status, then the dyspnea can occur. Right, so it determines whether or not you're getting enough oxygen and expelling enough CO2, and it compares to like how fast are you breathing. You can tell where the chemoreceptor zones are, where you will be monitoring for your CO2 and your PCO2 here in the carotid bodies. So this goes a little bit more in depth than the other slide. It shows you exactly where you, with the carotid body, if you see your oxygen goes down and your CO2 rises, it does tell your CNS like there's distress, there's something that's not going on. Correct. And it's located in your aortic bodies. And it also looks at, it's not on the slide, but your pH2 of the blood. What is that? What is happening with the pH of your blood? Is it more acidic? Is it not? And it also connects with, when you're CNS, you're looking at your 9th and 10th cranial nerves, When there is an increase in your CO2 and a decrease in your PCO2 or decrease in your pH, the carotid bodies are stimulated and they lead to a stimulation of respiration, right? And we look at the VQ, which is your ventilation versus perfusion, also to help determine how well are you breathing. On this screen shows you different areas that could be affecting your CO2 or your PCO2 or acidity in terms of what could be going on in your lungs, where you could have airway obstruction, asthma, emphysema, pulmonary fibrosis. So anywhere where there's an increased mechanical load on your lungs, pulmonary embolus, interstitial lung disease, where there's inflammation, infection, fibrosis, pulmonary hypertension, or if you have deflation of your lung in a pneumothorax or hemopneumothorax, a collapse, or effusions. You know, a lot of our cancer patients at end stage cancer can get effusions, so a lot of buildup of fluids in the lung. That slide, as we just talked about, went over some of the different types of dyspnea, but this also gives you a little bit of a just list of what you could see. But an easy way to remember it is 6 P's of dyspnea. So pulmonary bronchial constriction, foreign body, pulmonary fibrosis, pneumonia, where we talked about having increase of fluids in your lung from your cancer or effusions. There could be a pump failure and a pneumothorax. So 6 P's of dyspnea can help you kind of remember all the different types that can cause dyspnea. How do you diagnose dyspnea? Well, obviously, we talked about that it is a patient rating system, like they tell you that they're feeling dyspneic. But you also can look at the underlying causes of why they're feeling dyspneic. So we should do a chest x-ray. Sometimes we'll do a CT scan if we want to have a more in-depth look about what's going on, especially if they have tumors. You're going to need to have a CT scan, and EKG, because we want to say, could it be related to the pump, your heart, that's causing this? ABGs, CBC, and Chem 12 to look at all your electrolytes and find out, which is your PCO2, CO2, and your pH. And then sometimes if the outpatient, so we don't do this really inpatient, pulmonary function exams and VQ scans, and those we really do for some patients we know have like pulmonary hypertension and long-term chronic lung issues. But we don't in the hospital when they come in acute stages and they're dyspneic. You're going to do the 3 above. How do we manage dyspnea? So non-pharmacologically, we'll put the head of the bed up. We can use a fan because the air on the face can hit our vagus nerve and it can make it actually feel like they're getting a lot of air and calm a patient down. Reduce irritants. So if there are things that are causing the distress for the patient, because anxiety can make dyspnea work, we try to reduce it. And cognitive, it's sort of more of like helping the patient focus and deep breathe so that they feel a little bit easier and relaxed while they're breathing. Sort of like counting, take a deep breath in, hold it, and then slowly release it. Management for pharmacology, we use opioids, analytics, oxygen, antipsychotics, bronchospasms like steroids or dilators, and antibiotics, depending on what the underlying issue is causing the dyspnea. Now, a few of these things, like your opioids, your analytics, your antipsychotics, are not going to treat the underlying cause of the dyspnea, where bronchospasms and antibiotics can treat the underlying cause. But the first 4 do not, including oxygen can, depending on what it is, but a lot of times it's just giving the patient a little bit of a relief from the mismatch that we talked about earlier about what's going on with your efferent and afferent pathways. When we use opioids specifically, it helps your brain kind of not see that mismatch as much. And it allows patients to feel at ease and relaxed, and their body isn't telling them, breathe faster. It does not take away from the underlying cause. So if they have an infusion with buildup in their lungs or pneumonia, or they have a cancer tumor in there, the opioids are not going to treat it, but the opioids will make the patient not feel like they have to run like a marathon and breathe fast. Anxiolytics are helpful when a patient is very anxious. So we know that when patients can't breathe, they probably feel like I'm dying, or that's how they describe it. And the anxiolytics can basically help reduce the anxiety piece. So sometimes we may use opioids along with anxiolytics, but we try not to do it too much together because I apologize, you may hear once in a while a kid turn on their video. Um, we are in Tahoe right now and trying to live in a small little hotel room and complete everything, whether it's schoolwork or teaching lessons. So if you hear random interruptions, it's a child. So anyways, let's get back to it. So anxiolytics, like I said, and opioids, we can use them together. You just need to be cautious. Most of the time we use these opioids and anxiolytics for patients who are terminally ill and nearing the end of their life because they're having distressing symptoms. And it's okay to use the two of them together because we know that the priority is getting them to be comfortable and not necessarily keeping them awake. Because if you use opioids and anxiolytics together, and sometimes antipsychotics, it can make someone very sleepy due to the side effects. Let's go into nausea and vomiting. So nausea and vomiting. Nausea is an unpleasant wave-like sensation at the back of the throat and epigastrum, which is difficult to suppress. It's a forceful ejection of stomach and intestinal contents through the mouth or nose or both. So it's not great. One of the worst things I hate in nursing is having to take care of vomit. It makes me feel like I'm going to vomit myself. But of course, as nurses, we take care of patients who are going to be vomiting. So how can we help them feel better? So we look at the causes of nausea, vomiting. And if it's easy to remember, we can do the 12 M's: metastases, meningeal irritation, movement, mentation, medication, mucosal irritation, mechanical obstruction. So like in our GI tract, when we have a bowel obstruction, it will cause people to be nauseous and vomit because nothing can go through. Motility, also related. So if they've got obstruction or a constipation, so nothing's moving, then that can build up the stool and cause someone to feel nauseous and vomit. Metabolic, microbes, mitochondrial, and maternity. How do we take care of nausea? Now, depending on what is the cause, looking at the 12 M's that we just talked about, we can determine which medications we can use. Now, I know the slide is kind of small, so I may put up a new slide that just has this a little bit clearer so you can see the drugs, what class they are, and how much we start with. So histamine antagonists that we use is diphenhydramine, meclizine, hydroxyzine. So these are more for patients who may have motion sickness or an irritant. You can use the histamine. It will make them sleepy, of course, which is a side effect, but it is helpful, especially in our vertigo patients. Acetylcholine or scopolamine patch is what we use for these patients. Know that a scopolamine patch, when you put it on, it does take time to take effect, usually about 24 hours. So, and you change it about every 3 days. But it does cross your blood-brain barrier, so it can make some patients more sleepy. It can also make some patients confused. So we really watch using the scopolamine patch in older adults, okay? It also a side effect of the scopolamine patch, because it's the acetylcholine antagonist, it can dry up your mouth. Dopamine antagonists are haloperidol or Haldol, Regland, which we had talked about earlier, using for constipation patients, Compazine, Phenergan, and olanzapine. The last one, olanzapine, is an antipsychotic, but it hits your dopamine and it hits actually your serotonin. So it is, and has a little bit of acetylcholine in it. So it is actually a very great drug, the olanzapine. The other name for it is Zyprexa. There used to be a lot of ads about it. I don't know if there's still ads out there on it. But Zyprexa can be given daily or twice a day. The side effects of Zyprexa are sleepiness, and it can prolong acute TC. So many of these drugs on the dopamine antagonist list can prolong your QTC. So olanzapine can, and Haldol can. So as we had talked before in another lecture, when you prolong your QTC, you're at risk for torsades. So a lot of these patients, if they are on multiple drugs, and then we add on these different drugs like Haldol or olanzapine, we could be prolonging their QTC. So always get an EKG for when a patient starts Haldol or olanzapine. Central acting medications that we sometimes use is dexamethasone or Decadron, THC, which only comes in Marinol in the hospital setting, and lorazepam or Ativan. Serotonin agonists that we use are Zofran or ganastrotron, which is another subset of Zofran. And then very rarely do we use dolanstron. So, but most of the time we use Zofran is our drug to go to. And as I said before, olanzapine also has serotonin agonists in it. And then if we have an inoperable obstruction, so if a patient, most of the time these are patients with cancer, a lot of times it's GYN cancer, which affects our pelvic area and can invade our GI tract. They can have inoperable obstruction. And with that, what happens is that despite that you have an obstruction, your body will continue to create intestinal coating or intestinal secretions, and using octreotide helps decrease those secretions so you don't have as much of a buildup, and hopefully won't vomit. This kind of gives you a little bit for memorization, which is always helpful, of the mnemonic vomit. So vestibular is a V, which is like inner ear movement, dizziness, or vertigo. You want to use acetylcholine and histamine drugs to hit any types of nausea or vomit relating to vestibular causes. Obstruction, which is the mechanical or the constipation, you use acetylcholine, histamine, and serotonin. So those are very effective. If you have dysmotility, chronic opioids, or anticholinergics, you use the same as an obstruction, except there's an actual 5-HT4 with another subset of serotonin. Inflammation or infection anywhere or radiation that causes inflammation, acetylcholine is again what you use, histamine, serotonin, interleukin-1. And then toxins or opioids, chemo, electrolytes, or imbalances, you use your dopamine and your histamine to use. Dopamine and serotonin. So if it's hitting your chemoreceptor zone, it's really the serotonin, which is the Zofran, is most effective in treating this. Now, back to on this slide, it does not have dopamine and where to use dopamine. So the two places that I would use medication that hits your dopamine receptor sites are going to be for obstruction and dysmotility. So in your GI tract, you have dopamine receptor sites there, and that would be when you use your for someone who has GI distress, or like a constipation or so, you would use it. And when we specifically the Reglan, when we use Reglan for dysmotility, especially if a patient says to you, I'm getting nauseous with eating, then you would want to schedule Reglan before they eat to help decrease the nausea, because you're hitting the dopamine receptor sites in their GI tract. It will also help them have a bowel movement that we talked about before in our constipation piece. So Reglan is most effective in our dysmotility patients. Oh, great. This slide is a little easier to see. So this, hopefully you'll be able to print out the lecture and you'll be able to see the drugs and the dosages that we typically start out with. And most of these you should have in the hospital setting. Now you can get nausea and vomiting related to radiation treatment. And depending on the fraction size, how long they're going to have it, can affect how much they'll have nausea and vomiting. And this slide kind of just tells you how often patients who were having nausea or vomiting and how often the rate of it. And in these patients, they were prescribed Zofran to help with it. So Zofran can be very helpful in patients with radiation treatment too. Now, Zofran is not the only one that we used. There are other medications that we can use, but most of the time it's Zofran. And as you see here, granosterone is something that we use too. The reason we don't use granosterone that often, so it hits more of the serotonin more than the Zofran or ondansetron, but it's very expensive. And you usually give it in only one dose, and it's an IV. Most of the time it's IV. So we like to use Zofran first. If the Zofran's not working and we know that it's related to radiation, or we really want to hit your serotonin, then we will use the granosterone. Corticosteroids are also helpful. And the reason we use corticosteroids is because most of the time when you're using radiation, it's looking at trying to reduce a mass or the inflammation around a mass. And steroids can help reduce that inflammation. So what we typically do for a patient who's getting radiation therapy and is nauseous or vomiting is we'll start them on a corticosteroid, and that's usually Decadron. And we can give a high dose usually as the first dose, which could be 8 to 10 milligrams in the morning. And then after that, they get 4 milligrams a day. Just for about a week. We don't do it for very long, and it's just in the beginning while they're getting radiation. Over time, the radiation would help shrink the tumor and their symptoms should be improved. Now, sometimes we do use a dopamine receptor antagonist like Reglan, or Phenergan, or Compazine, but they aren't as effective as the 5-HT3s. Delirium. Now, every one of you is going to deal with a patient who is delirious. The reason why is because we see delirium increase twofolds in our patients who are admitted who have underlying end-stage dementia. And we see dementia in our hospital quite frequently. We also see it in our ICU. ICU delirium is prevalent. When someone is very sick and they're getting a lot of medications, delirium can easily occur. So it's important for all of you to understand delirium and also know the CAM evaluation, which is used quite frequently in the ICU and in other locations of the hospital to determine if a patient has delirium. So delirium, obviously, this picture depicts a patient and he sees a cat at the end of his bed. We typically do not allowed cats in the hospital, so he's seen a hallucination. Delirium is an acute onset of an impaired cognition, attention, consciousness, perception, sleep patterns, or emotional states that fluctuate over a course of the day. Now, a patient can be delirious in the morning, and in the afternoon, their delirium clears up, and in the next morning, their delirium comes. So a patient can be delirious and have moments of clarity, but still we would consider them delirious. You probably have heard sundowning syndrome in our elderly adults who sometimes in the evenings as the sun goes down, they become delirious. What are the causes of delirium? Reversible versus irreversible. And reversible, sometimes we say 50% of the time, depending on the underlying causes and if we can find out why they're having delirious. So causes of delirium could be metabolic, fluid imbalances, dehydration, especially in our elderly patients, medications, liver, kidney failure, so if you build up of toxins, hypoxia, hemolytic imbalances, hematological imbalances or like anemia, constipation, and urinary tension. And I want you to really focus on the urinary tension. A lot of times in our elderly adults, sometimes more in our females, they might get a UTI and not have any symptoms or, either never a fever, never pain with urination, but all of a sudden they get confused. The first thing you should also do in that when you're taking all their blood work and stuff is do a urinary, test their urine. See if they're having any types of infection. So you want to do a urine culture. So the CAM is a confusion assessment method, and this gives you a little bit about how to do a CAM. Now, of course, as nurses, it's important to do a CAM with your patients. You don't have to necessarily do it every day, and you probably will get the hang of making your own assessment. But the physicians also do a CAM assessment on a patient every day when they round, just to determine is the patient delirious or not. So a diagnosis of delirium is suggested if question 1 and 2 are yes, with either yes from 3 or 4 or anything other than alert in 4. So if they have a sudden onset of confusion, so it's acute, right? So this is not over a long period of time like dementia. Does the patient have difficulty focusing attention, for example, easily distracted or has difficulty keeping track of what is being said? So they can't recall, they're confused. Disorganized thinking. Is the patient's thinking disorganized or incoherent, such as rambling or irrelevant conversations, unclear or illogical flow of ideas, unpredictable, switching from subject to subject? If they become violent, or if they become hypoactive. So also know that delirium can be hypoactive, where they stopped interacting. And then the level of consciousness. Overall, how would you rate this patient's level of consciousness? Are they alert, vigilant, lethargic, stupor, coma, or uncertain? So know that there is hyperactive delirium and hypoactive delirium. There are 2 types of delirium. With the hyperactive delirium, they will be awake, but confused. They could be violent at times, or try to get out of bed, less able to focus or follow directions. Where hypodelirium, you'll see, will be more sleeping for most of the day, lie in bed, less interactive, not following directions, but mostly because they're somnolent. So what are the things that we can do to treat delirium? So it's dependent on the type of delirium that they have. What you want to try to find out is what is causing the delirium. Are there medications that they're on that could be causing the delirium? Should we take those medications off of them or switch them to new things? If they're on high doses of opioids, which we know high doses of opioids can cause some cognitive effects, should we switch them to a different medication? Like I said about scopolamine, that crosses the blood-brain barrier. Is this patient on scopolamine? Should we take it off? Those are types of things. So looking at what could be causes of the delirium. What we can do to treat them, once we have looked at all the different causes that could be, underlying the symptom of delirium, we want to treat them. So we can do mentally stimulating activities. They're trying to be more awake. So playing word games with them, reorienting them, discussing the events. It says singing songs, but that's up to you. You don't have to sing songs. Sensory stimulating activities. So one thing is really important for elderly adults is a lot of them probably wear glasses and have hearing aids. It is very important that if they have those, that we put them back on. Let them wear their glasses, put their hearing aids on. If they're able to refocus and be more interactive in their day, that can help reduce more confusion. The other thing is sleeping activities. It's important to have a sleep-awake cycle. If a patient is off their sleep-awake cycle, especially our elderly, they can be easily confused and get delirious. Orienting medication materials. This is why one of the things that we have clocks in every room and calendars is because it helps orient the patient. So when you come in, most places have a whiteboard that says the date and who is part of the care team and stuff. It's important to keep those updated to help the patient be aware of their surroundings and what day it is, because it can easily be confused in a hospital where you don't go outside and the windows are all closed, or if you're in a 2-bedroom room, you may not even see a window. So it's always important to update those. Mobility activities is important, walking around as much as they can. Physical therapy should be involved if they have a aggressive treatment plan. So make sure physical therapy is in there. Nutrition, hydration, like we said, in our elderly, they are more prone to dehydration, and especially in the hospital, we should be watching that. They should already probably be getting some fluids, but be mindful of that. And then any environmental activities that you can do and help keeping them more interactive with their surroundings. Sometimes they may need a sitter if they're very delirious and hyperactive for the safety of the patient. That sitter can be very helpful for you in redirecting the patient and keeping them interactive, keeping the wake sleep cycle going. So these are all different things you can do as a nurse to help with a patient who's delirious. Terminal delirium is where we find a patient, we've tried to turn around what could be causing their delirium. They may be at end of life, and now it's determined that the delirium is unable to be turned around. And instead of putting through more tests and interventions, we decide to treat the symptom of delirium with antipsychotics. And this is for our patients with hyperactive delirium. So they're being aggressive or they're having a significant amount of confusion. This is not necessarily for patients who have hypoactive delirium, who are sleeping, not interacting, awake. Patients with hypoactive delirium, we just make sure that they are not having any other symptoms of distress like pain, nausea, vomiting, shortness of breath, but we don't necessarily start them in on antipsychotics. When we're treating delirium with antipsychotics, we're basically sedating the patient so that they are not having so much distress from their confusion or hallucinations or whatever it could be caused. This is the only time, though, we also use benzodiazepines, like Ativan, sometimes for SED. And the reason why is because this will be very sedating for the patient, and we're using high doses to keep the patient calm. Other thing, just for you to know, back to the terminal delirium. When I do treat terminal delirium, similar to delirium that's not terminal, on a patient who's actively dying, we still use Haldol. So Haldol is your go-to drug, right? And you still start Haldol low, no matter who you started out with, unless they've already been on Haldol. And you would start Haldol like 0.5 IV for patient with delirium, similar for terminal delirium, and then you increase as need be. So Haldol is still a very important drug for delirium in any case. It is when we find that the Haldol is not working that we use Ativan at high doses. And when I say high doses, we usually don't start at 0.5. We're starting at like 2 milligrams to basically sedate the patient. So, back to the terminal. So, and Haldol, as we talked about in our nausea vomiting piece, it hits your dopamine receptor sites too. It is an antipsychotic that can prolong your QTC. So if you're using in patients who do not have terminal delirium, you're going to want to take a EKG when you start Haldol. Terminal secretion. So this is something that we see quite frequently in our patients who are pretty somnolent. It's also called the death rattle, but we don't use that anymore. Some patients may have heard about it and may come up, but most of the time we call it terminal secretions, or in your order sets, it will be secretions. And what happens is that the fluid pools in the back of our throat at end of life. It's not painful, and we treat it with anticholinergics. Every day we make about 1 liter of saliva. And when a person loses ability to swallow, or they're somnolent and they're not going through the motions every day, just like as we subconsciously swallow our secretions, when patients are at end of life and they don't have that reflex anymore, the fluid starts pulling the back of the throat, and that's where you get the death rattle. With this terminal secretions, there are things, like I said, the anticholinergics we use. Typically, our drug that we use most of the time is Robenol, that you can give IV, about 0.2 to 0.4, and you give it every 4 hours. We also use a scopolamine patch that we had talked about, which dries the secretions. It does cross the blood-brain barrier, so you don't necessarily want to use that on a patient who may be alert and awake and interactive. But your patients who are more obtunded, somnolent, not interactive, the scopolamine patch can be used. We also use, the other thing is atropine drops that you can use. And we use that a lot in our hospice, home hospice. It is just atropine drops that you put on the tongue to help dry it up. Unfortunately, there isn't really a good solution to terminal secretions. There have been many studies looking at these different drugs, and there really hasn't come up with one drug that's been superior or actually even as effective to treating these terminal secretions. So as nurses, we just need to support patients' families or whoever's at the bedside to let them know that it's normal and it doesn't hurt the patient, because most likely, even despite putting on those medications, the patient will still have secretions. Depression. Now later in this course, I'm going to have you watch a video on depression in our elderly, because this is a rising symptom and disease that we see, a mental disorder that we see in our elderly patients. And actually right now during the COVID, we are seeing depression scores or depression rates increase substantially, especially in our elderly who are now being really limited on going to public places and being out. I mean, I haven't necessarily seen my mom that much in the last 6 months, other than here or there, and by, of course, FaceTime, but she's been really isolated into her home. And this is where our depression can heighten, when we're away from everyone, and if we already have a little bit of depression. So in the palliative care literature, there's a wide range of scores where we see depression. In some articles, we see it at 25, and there's other that are 75%. Unfortunately, there's a lot of limitations in the study designs, and there wasn't really a distinction between clinical depression and depressive symptoms. So patients at end of life can have depressive symptoms, but not necessarily clinically depressed, where we would start them on an antidepressant. In depression in the United States, a 12-month prevalence is about 8.6% of the population, with a lifetime prevalence of 16. Now, these rates are going up, though, unfortunately, because of the pandemic that we're in. Now, major depressive disorder is when we see patients with a depressed mood or loss of interest. They just tell you, I don't have any hope. They have weight loss, appetite loss. This is going on for a long period of time. It's not in an acute phase. They have insomnia or hypersomnia, so they're sleeping all the time. Psychomotor retardation or agitation, fatigue, loss of energy, really not doing much, feelings of worthlessness or guilt, poor concentration or indecisiveness, and recurrent thoughts of death or suicide. And when we talk about this in the major depression, this is for a long period, okay? This is not just for in a day or so, you know, when you may see them in the hospital. This is sort of a, how long have you been feeling this? You know, if it's just a day or so, they don't have major depressive disorder. If this is going on for months to year, then we kind of say, okay, this is something more long-term. It's very important to ask if someone is telling you, I'm feeling hopeless, I don't feel like life is worth living, is to ask them if they are suicidal. You know, are they having thoughts about death? Are they having thoughts about hurting themselves? If they say yes, then the next thing is like, have you made a plan? And if someone tells you that they have thought about hurting themselves, and especially if they have a plan, but if they have thought of hurting themselves, advocate that a psychiatrist sees them. With our patients with chronic illnesses, it's not uncommon for them to be depressed. And especially in our cancer patients and our patients that are going through stem cell transplants, we actually see somewhere in the rates of 75% of those patients after a transplant can have depression. Because they're so sick and with a chronic illness, and it precludes them from really enjoying them in life, then it's important to get a psychiatrist involved in their care. Now, adjustment disorder is a little bit different. It's emotional and behavioral symptoms in response to an identified stressor occurring within 3 months of onset of the stressor. Marked by distress that is out of proportion to the severity or intensity of the stressor. It can be significant, impairing social, occupational, or other important areas of the function. So these are patients who have a stressor that come up, whether they were told that they had, you know, progression of their disease. But it maybe not be as severe as the patient is making out to be, but the distress is very, for them, overwhelming and impairing their ability to maybe even come to get their chemotherapy or their doctor's appointment. These are patients also that we want to focus on and just help get some support, mental support, whether it's through the therapist or psychiatrist, because this adjustment disorders can affect patients' ability to actually follow through with their treatment plans. In terms of depression therapies that are out there, it's really focused usually on not only the psychotherapy, so also talk therapy is very important. CPT therapy is very, cognitive behavioral therapy is very important. But sometimes we use pharmacokinetics and some medications. And this is where, you know, where you need a psychiatrist to be involved. Some of our primary care physicians may feel comfortable doing low-level depression. However, in our chronic ill patients, I actually really recommend that you have a psychiatrist be involved, because they're usually already on so many medications that you want to not add more burden to them, and having a psychiatrist involved that can find the right medication that works with the medications that the patient's already on is very helpful. PTSD is another symptom that we are seeing in our patients with long-term illness disease. And there are new therapies out there that are not just medications. There's a new therapy called brain spotting therapy, which is kind of finding where in the brain with a psychologist or therapist about where it triggers a patient. So there are many different things out there that are not just medications, but you do need a professional help kind of provide those. As nurses at the bedside, we don't necessarily be able to provide them, but we can give them resources for patients to go to find this type of help. This is just a little bit of an overview of the depression medications, but we're going to go into this a little bit later also. I just want to give you a list that we look at. So SSRIs or SNRIs are one of the main drugs that we use. Buprenorphine, Wellbutrin, or Tazepine, or Remeron are things that we use. They are really great for, mirtazapine is really great for patients who also have nausea because it does hit your serotonin receptor site, and then it also stimulates appetite. Stimulants, so sometimes we do use stimulants in depression and not necessarily for long term. So like SNRIs and SSRIs, they can take up to 2 to 4 weeks to really hit for patients' depression to see a difference. That's a long time when someone is depressed. So sometimes we add stimulants to help patients kind of feel more energetic and wanting to be active. It doesn't treat the depression, it just allows the patient to feel like they have energy again. Methylphenidate and modafinil or Provigil are the 2 drugs that we use most of the time. And as I said, it's for short periods of time. Other drugs that we've seen have helped in depression that there's more evidence that's coming out with is ketamine and tricyclic antidepressants. Also, gabapentin has been shown to be helpful with depression at low doses. Gabapentin usually starts at like 100 milligrams 3 times a day, and then you can increase, but it has been shown actually to be helpful in depression. While we have ketamine on here, it's cautiously used, okay, because there are side effects, like you can cause hallucinations with it. So while it's been seen to be helpful in depression, we also need to watch out for some of the side effects. So pruritus, the unpleasant sensation that provokes desire to itch. And many things can cause pruritus. A lot of times that we see pruritus in the hospital is going to be related to either drugs. So if it is related to drugs, then we stop the drug that is causing the pruritus and give Benadryl. Or the other thing we see is a lot of time in liver disease that patients can have pruritus. So chemical mediators, which cause the pruritus, are histamine, serotonin, cytokines. All right, that's right. Opioids, neuropeptides, or substance P's. These are all things that can cause pruritus. Neuropathic pruritus, or damage along the afferent pathway, is both hepatic itch or brain tumors. A lot of times with shingles, of course, shingles can be very painful. Psychogenic pruritus. So when we see psychogenic pruritus, and a lot of times I see this is with our patients who have shingles, and the shingles is treated, but they still have the pruritus from it, and it's gone, but psychogenically they still feel like they're itching. And neurogenic, which is centrally induced and not responsive to histamine. Our uremic renal failure, we see it all in, and the cholestatic itch, our liver failure patients. Non-pharmacal ways to treat it is avoiding the sun. We use ice or cooling measures, skin hydration. Sometimes ultraviolet B light can be helpful. Of course, that wouldn't necessarily be done in the hospital setting. They could do that outpatient. You do it 3 times a week, and it helps decrease the mast cells that are accumulating, and then it can also help uremia. And then for our patients, like we've got obstructions or so, then we need to put a stent in, a biliary stent in. Sometimes we put a biliary drain in, and then can help with the pruritus. Pharmacologic medications that we use are antihistamines, H2 antihistamines, serotonin receptors and antagonists, so mirtazapine, another great drug to use, and Zofran. So if we think that that's be responding to serotonin receptors, then you would use these two drugs. Zofran could be very helpful. For atopic dermatitis or TCA related, doxepin is also very helpful. And then our uremic patients, colostrum is something that we use. Fatigue. This fatigue is an ambiguous phenomenon described as a persistent sensation of tiredness, lack of energy, or exhaustion. It can be very easily tiring. And a lot of times we see this in our cancer-related patients. Sometimes we call it failure to thrive, but it's because they are so fatigued they can't do anything, can't even get out of bed. To treat fatigue, we try to do energy conservation and improve their sleep hygiene. So what do they really need to accomplish during the day? That's what you should focus on. Don't do other little small chores, just do the main things that are more important. Pharmacological, we'll look at why they're feeling. Are they anemic? Do they need a blood transfusion? Are they depressed? Are we treating their depression? Is it disease related? So our cancer patients, those patients who are on chemo, sometimes they can be pretty fatigued following it. And then CNS stimulants is sometimes we can give, and that's what we talked about before in our depression piece, is looking at Provigil or methylphenidate. Can we use those to help increase their energy? Hiccups is a common thing that we see, especially in some of our patients who may have a GI issue, which is hiccups is a spasmodic contraction of the diaphragm that repeats several times per minute and causes disruption in intake of air, closing of the epiglottis, and a hic noise. Non-pharmacal, you can try stimulating the soft palate to see if that will stop. There's many multiple homeopathic remedies out there, and I don't know all of them. Of course, you probably all know some of them, of like holding your breath or someone scaring you to basically disrupt the hiccup. Whether or not those work, and I don't know the studies regarding those, but those are some of the homeopathic remedies. Depending on what the cause of the hiccup, you can try an acids, dopamine antagonists. Reglan has been helpful in these patients. Muscle relaxants like baclofen, and another drug that I really like with hiccups is gabapentin, because it affects your NMDA, or central nervous reflex sensation, so it can help with hiccups. Again, you start low with gabapentin, like 100 milligrams, and you do it 3 times a day to help with the hiccups. You don't necessarily, it's not as needed. You schedule gabapentin to help with someone who has long-standing hiccups. So if it's someone just started to have hiccups that day, you wouldn't necessarily start gabapentin. You may start like Reglan or looking at acids. It's more for patients who have longer term hiccups, and that's when you would look at baclofen or gabapentin. Thorazine is sometimes what we use, but the Thorazine will be very sedating, so I don't put that as one of the drugs I go to. It's like a last one to go to. These are more the ones we use. Insomnia is difficulty falling asleep, difficulty maintaining sleep, waking up really early in the morning, and also not getting refreshing sleep. These are all different descriptions of insomnia. Non-pharmacologic treatment of insomnia is try to help them with sleep hygiene. Can you turn off all the lights by 9 o'clock at night and then set a timer for the morning to get up? Can you do meditation, biofeedback, music, turning off TVs, putting your phone away? Trying to get things to just get your body to relax and hopefully release the melatonin, which helps us fall asleep. So we all make our own melatonin in our body, or a derivative of melatonin, from our pineal gland in our brain releases melatonin when the sun goes down. And that basically gets our body to say, okay, fall asleep. It doesn't necessarily keep us asleep, but it makes us fall asleep. So when we look at pharmacologic treatment of insomnia, we're trying to figure out what can we use. So the first drug that I usually use, it's not on this, but it should be on here, is melatonin. Like I said, we produce our own derivative of melatonin from our pineal gland. And sometimes we may not produce enough. So we can try to supplement it by taking melatonin. Melatonin can come in doses of 3 or 5, up to 10 or 20. And you would usually start between 5 and 10 at nighttime before you fall asleep. So don't be taking it at midnight, take it about 9 and see if that's helpful. I usually start them on all my patients who are elderly in the hospital if they're going to be there for a long time, because it helps keep them on a sleep-awake cycle when it's really difficult to do in a hospital setting because you're coming in a lot and disrupting their sleep, just because that's part of what we do in the hospital. So the elderly sometimes need a little extra help, even if they're saying, I'm not feeling insomniac. When melatonin doesn't work, then we go on to other medications that basically keep a patient asleep, kind of gets them to fall asleep. So trazodone actually is very useful in our elderly patient. It doesn't have all the side effects that other drugs like gabapentin does, or amitriptyline does, or antipsychotics do. So trazodone would be usually my first drug to use in elderly, and you can start off at 50 milligrams and keep going up like to 100, but it keeps the patient more sedated at night. GABA receptor agonists like Ambien can be used. Now the thing with Ambien though, and you probably have heard, is that it's not very recommended in elderly. It can cause patients to be confused more. And so Ambien we use more in our younger population. So just be aware, trazodone for an elderly, Ambien for our younger population. Amitriptyline can be used also in this population, but it is not first-line drug because it does have a large side effects profile and can really sedate a patient. Same thing with antipsychotics. They can really sedate a patient. And the last one that has on here is that antihistamines and benzodiazepines are not recommended really in elderly at all for sleep. It can really sedate an elderly patient significantly. And the other thing though that we see in the elderly patient, it can cause a paradoxical effect. And when a patient has a paradoxical effect to benzodiazepines or antihistamines, it can be significant. They become very delirious, agitated, and it can be in their system for a long period of time. So we try not to use antihistamines or benzodiazepines for sleep as a drug to go to. Now I'm going to go a little bit into cannabis because I think that we have all seen cannabis have a rise in popular support for our patients. And you'll probably see patients who come in and tell you, oh yeah, I take cannabis on a regular basis. So you should know what that means when someone takes cannabis, especially on a regular basis. And are we allowed to do that in the hospital, or do we have anything that's similar compound to cannabis in the hospital? So what is medical marijuana? Medical marijuana is the use of cannabis or cannabis products in an attempt to treat disease or alleviate symptoms by patient choice. Understand that there is a lack of a perceivable or controlled trials in this right now, showing favorable efficacy and safety of these products. Now, there are more ongoing trials looking at cannabis, but right now there isn't that many because federally it is considered still Scheduled 1 drug. And you need to get some permission from the federal government to do trials on drugs like that. So cannabis can be a source of fiber, food, oil, or medicine. Marijuana is dried mixture of cannabis leaves and flowers. And then the whole plant is a conception that the plant products from the entire cannabis plant may be better than the individual cannabinoids. So cannabis sativa is a type of cannabis that you'll see out there. There are 2 varieties of cannabis, sativa and indica. And these are considered subspecies of cannabis. And so a patient may tell you that this is what they are taking or from one of the dispensaries. And usually it has in it, depending on which one, the sativa has less THC in it, where the indica has more of the THC in it. Now, what does that mean? So with THC, when we look at it, THC is more of the cannabinoid that causes patients to have more of a high feeling when you take cannabis, where CBD cannabinoid does not create the high. So when we're looking at these two different subspecies, a patient is either using the sativa because they don't want more of the high component of the cannabis, where with the indica, they may want more of the high substrate of the THC cannabinoid. Hemp is the strain of cannabis of the sativa, historically grown for the fibrous material and stalks and seeds, and it contains minimal THC and CBD. So it doesn't really contain a lot of these cannabinoids that we use for symptom management. Phytocannabinoids is, as we learn more about cannabis, we're finding that there are many, many, many different types of cannabinoids in the plant itself, about 100 if so we found right now. And we're not going to go into all of those. Actually, we're going to speak in general terms, and the general terms are going to be the THC and the CBD. But know that these can be even differentiated even smaller than just THC and CBD. This just gives you a little understanding that there are so many different cannabinoids in it that it's really hard to speak to one or the other. That's where if a patient wants to seek treatment using cannabinoids, that they need to go to a pharmacy, and they're considered pharmacies, a marijuana pharmacy where they should have, if they go to the right ones, like a pharmacist on there that is able to say what is in each type of, brownie or vape, depending on what the patient used, but whatever they're using to get their THC or CBD, the pharmacist of that dispensary should be able to tell the patient what cannabinoids, as much as they can, is in that product. So the history of medical marijuana, just to give you a little understanding how long marijuana has been with us. It was first used in Central Asia with a subsequent spread to China and India, probably through the Silk Road trade during that time. And the Chinese Emperor Xingnong prescribed it more than over 5,000 years ago. And then between 2000 and 1400 BCE, it's thought to have been made in India and then Egypt and Persia and Syria. So it's been around for a very long time. And it first got to the Western medicine from an Irish physician who brought it over. So this is just a newspaper from 1843 and talking about a little bit about the cannabinoids, and here, the Indian hemp. It's been around for a while. It was listed in our U.S. dispensary in 1854 and apparently widely used in many different products. I mean, you can see even here, the Reefer Madness was in 1936, and it was out there for anyone to take. You didn't need a prescription. But despite the American Academy of Medicine objections, the Federal Bureau of Narcotics pushed for a congressional passage of the Marijuana Tax Act. So basically, it started taxing the cannabis, $1 an ounce for medical purposes. And then was highly more expensive for unapproved purposes. So, and this is in 1937. So they started taxing marijuana. And then in 1942, it was actually stripped of the therapeutic legitimacy. So they took it way out of the U.S. dispensary, not even sold anymore. And it wasn't until the 1970s that Congress renders marijuana illegal. And the FDA soon designates it as a Schedule I drug, which is typically what you use for what they consider street drugs. And if I'm probably aging myself, but in the 1980s, during the Reagan administration, Nancy Reagan really took on the role of making marijuana look like a gateway drug. And some people still believe that it is a gateway drug, meaning that you start using it, that you'll start using other drugs. But in 1996, California was the first to legalize cannabis with a wide latitude for use, not only for serious medical conditions, but for any other illnesses for which marijuana provides relief. So California was one of the first states to start to use cannabis again for treatments. And it was very broad on who got considered medical conditions. So we had many people asking for medical cards to get cannabis. Now cannabis is more widespread in the United States and being more acceptable on the state level, not on the federal level. We have looked at cannabis in the inpatient side, or not just inpatient, but for patients that we can use to treat different symptoms that patients may experience. Now, the thing with cannabis is that because it's a federal Schedule I drug, we cannot provide cannabis in the hospital setting in the terms of like a tincture or the plant itself type. We can use synthetic drugs that replicate what cannabis is. And the only synthetic drug that we have legally here in the United States is Marinol. Marinol is a synthetic THC. It does not have any CBD in it. And we have found that Marinol can be effective in many different patients, but one of the ones we've seen recently, and Connie Carr, along with Dr. Frank and Dr. True, presented this, was using dronabinol for treatment of paraneoplastic night sweats in cancer patients. So it's not uncommon for cancer patients sometimes to have night sweats. So they looked at using a synthetic cannabinoid to treat the night sweats, and it had been effective. They looked at a few case reports and looking at it. So we do have synthetic THC that we can use. Another time we use synthetic THC is for patients who may use cannabis on a very regular basis in the outpatient side, but they come in and they didn't bring their cannabis in. You may start them on high doses of the Marinol to help them kind of coat them through the hospitalization until they can go home and restart their home cannabis that they use. Now, cannabis has been starting to be used more often too in our pediatric patients for epilepsy who have not responded to other anti-epileptic medications. So this is just an article talking about pediatric treatment-resistant epilepsy and having to use cannabis or cannabinoid medications to treat the seizures. Now, what are the side effects that you may see in the sativa? You may have mild euphoria, relaxation, perceptual alterations, dysphoria, anxiety, paranoia. But these are the paranoia and anxieties are usually related to links to patients who may have already had schizophrenia. So there is varied. And like I said, there is not a lot of studies out there, but these are some of the side effects. Now, you really can't overdose on sativa. Like you can take a lot of sativa, but it won't kill you per se. You may have more of the side effects that they may describe here, but it's not going to stop your breathing or stop your heart. Other side effects that we've seen patients with heavy using is like increased heart rate, decreased blood pressure. You may have some cognitive impairment or memory defects. And like I said, it's not going to actually kill them, but they may feel more anxious at times, and overwhelmed, but once it gets out of the system, it improves, and usually it takes about a day. So looking at the mechanism, the understanding it, and as I said, it's still very new for us in the medical field. There isn't a lot of information out there for cannabis and how it works. So it's sort of trying to go off of what we have seen. In the small amount of literature. Okay, I can't go back. Basically, give me one moment. Let me go back to that slide. Okay, sorry about that. So, Okay, so basically, the endocannabinoid system, what happens is that the cannabinoids affect places in our frontal cortex, our basal ganglia, hippocampus, cerebellum, glutamatergic and GABA neurons, and it affects these areas similar to other euphoric medications, where it hits like the and I cannot pronounce this word, so I apologize, but anandamide, and gives you this euphoric kind of feeling, especially with the THC. Common patients who could get these here in the United States, and certain states that allow it, although anyone in California can have it, but in other states where it's just for medical use, it's usually cancer, epilepsy, chronic pain, glaucoma, HIV, AIDS, ALS or MS, nausea, muscle spasm, cachexia, or terminal condition. And this is if you want more information on how cannabinoids work for pain, because that's what we see a lot in patients using it in our facilities, using for pain. This is the website that you can go on. All right, I think that I'm going to stop there for now, and I'll do another website just because my kids are starting to come back and harass me, and I will put another up, more information about for symptom management for cannabis for these medications and stuff. So look for a small little video on how cannabis works for acute pain and neuropathic pain.